All working? So it's a great honour and pleasure to be here at PSG. This is my third time in India, and I always love it. I'd like to thank Rutul and the organising committee for inviting me. Some terrific presentations this morning with a little bit of overlap with what I'm going to say. So I'm going to talk about the new paradigm, and it's kind of been touched on this morning, but I'm going to hopefully make it a bit more concrete. So I've got no disclosures, and I think it's always good to know where someone's come from. Obviously, all of you have come from different states in India, and I've heard how all of the states are just so different. So up here I'm about an hour from the beach. I'm just near, there's a hill behind me, a forest. I've got kangaroos just about 150 yards away from my house. Every now and then we have snakes, including in the garden, unfortunately. Not usually the red-bellied black, but a brown. And I'm actually in Campertown, just at the edge of Sydney, southwestern Sydney. And it's the most multicultural city in Sydney, and in fact probably in Australia. We've got 150 different languages and a very large Indian, South Asian and other populations. And I do the diabetes and pregnancy clinic there and was director of the service. So what I'd like to cover today is a bit of background, evidence for early under 20 weeks GDM, and that was how it was defined by the IPSG. Evidence for treating early GDM, and that's heard toboggan, and some implications for clinical practice, which this morning's come out, these four different modes of transport, and obviously there are those that can afford a lot, and those that can afford little. I've kind of a philosophy that you offer people the best that they can, rather than having everybody down at the lowest quality, which happens in some countries on the basis of equity. So we have touched on this before this morning, but just to remind you that the WHO classification is pre-gestational diabetes, so known type 1, type 2, and other rare forms of diabetes. And the IDPSG said overt, but the WHO said diabetes in pregnancy. So that's those who, on the GTT or on an HbA1c, would have been diagnosed with diabetes outside of pregnancy. And that's important because they've got similar risks, perhaps, to malformations. And then what I'm going to be talking about is gestational diabetes, which is diagnosed for the first time in pregnancy and not expected to continue postpartum. And the IDF Atlas, we based the prevalence of hypoglycemia in pregnancy, including 79% GDM, 9.9% overt diabetes in pregnancy. We've based that on the WHO IDPSG criteria, which, as you heard, is important because of the different sensitivity for hyperglycemia. And if you look globally, then the standardized prevalence of hyperglycemia is 19.7%. 80% GDM, 23 million live births. If we look at, it says Southeast Asia, but when I look at the map, it's actually South Asia. 31.7% prevalence, which is the highest prevalence in any of the IDF regions. 7 million live births. Of the live births with hyperglycemia are here in South Asia. And again, coming back to Indian history and folklore, so I thought this was absolutely apt. And I mentioned that the IDF Atlas uses the WHO criteria, but of course, lots and lots of different criteria, which is what we've heard today. And we've heard in the United States using the Carter-Kustan 50-gram test, 100-gram GTT, 3 hours. The Dipsy one we've heard today in different ways is something more accessible, something that people could do without fasting, using non-fasting 140 milligrams per deciliter. But globally, most of the international diabetes organizations were using the WHO, but now increasingly we're looking at perhaps slightly higher cutoffs. Canada immediately used 50-gram glucose challenge test and what was called the odds ratio of 2, so twice the chance of complications. And using these high cutoffs of 95, 191, 162. In New Zealand, what they've done they're just introducing not a 2-hour GTT, but a 1-hour GTT, which is happening outside of pregnancy as well. Increasingly we're moving, which I think will be great for the women, and they're using a 95 and 191 cutoff. So that odds ratio 2, but dropping the 2-hour. And in Australia, we've just moved to these cutoffs as well. We've moved away from the WHO cutoffs and moved to 95, 191, 162. And we're using them in both early and late GDM. And in Belgium, which is hard to see, it's down here. I hope you can just not see that. I will. So in Belgium, what they've done is they've taken toboggan and they say, right, we're going to use the odds ratio to 95, 191, 162 in early pregnancy, but there's not enough evidence to shift us from the WHO criteria at 24 to 28 weeks. And I'll come back to these different perspectives at the moment. So traditionally, and this is kind of coming through this morning, what we've done is we've said, look, we're treating hypoglycemia in pregnancy. For Carpenter-Kustan, we're trying to look at type 2 diabetes in the future. We're also trying to prevent pregnancy complications for the mother and also the baby. More data shows us that cardiovascular disease, GDM. So we're trying to find women so we can prevent the type 2 diabetes and the heart disease downstream. And the intergenerational effects, we hope that we can act on those. The evidence really isn't there at this point. But if you stand back from this, the women have come in with risk factors, either genetic, epigenetic, or environmental, and they've come out with the same risk factors. And if we think about then early in pregnancy, and I'm taking this from the elephant with the blindness, so that we're half blind here is what the perspective there is. In early pregnancy, of course some of the women are going to come in with a slightly high glucose. It's obvious. So the paradigm shift, which is just down here, is GDM is not just about pregnancy. It really is a life course and intergenerational condition. And we have to shift our perspective because it changes the rationale behind what we do when we're trying to do our best for our women. And you've already seen the Frankel slide, which said, look, GDM starts 24 to 28 weeks, middle resistance beforehand, and that's it. And sadly, I think it's quite clear that that is not correct. That assumes that the insulin resistance and insulin secretion is okay, glucose is okay. It only goes bad when the insulin resistance increases from around 17, 18 weeks in particular, and the type 2 diabetes pops up afterwards. And we've already heard this morning about the primordial prevention from Professor Sushia, and saying, look, 8 to 10 weeks is an important time to trying to reduce the impact on the fetal beta cells. But we do need randomized trials to show whether this is really going to make a difference. So what's really happening is this. We know they come in with their risk factors, they go out with their risk factors. They're coming in. Some of them, there is a balance between their insulin resistance and secretion, but they're not okay, and as we've heard, there are different phenotypes, it's heterogeneous. But the glucose is okay at that point. And the others have early GDM. And so what we've been using GDM for a conflated group. Those at the highest risk of future complications, and those who develop a bit later on because insulin resistance and insulin secretion capacity was better early in pregnancy as part of a continuum. So what's the evidence for me saying that? Well, first of all, we know, and this is from the Atlas again, we know that depending on your age group, between 6% and 14% of women are going to come into pregnancy with IGT in the reproductive years. And we know that between 5 and 10% are going to come in with impaired fasting glucose. They are hyperglycemic early in pregnancy. That will have an effect. We also know in the States, where, as you've heard, they've still not accepted early GDM as a concept. They say GDM is only here. If you put the sensors on early in pregnancy, you actually see that the women track through with their hyperglycemia. But again, it suggests that they're homogeneous. It's all of them. Well, it's not. Some have come in with their early GDM, and others, there's a balance, and they'll develop GDM later on. As you saw in that picture before, the incident, I call it incident GDM, no one else does. And we know that that hyperglycemia early on correlates with LGA and cesarean section. This is at 9.5 weeks. This is an Israeli study. And you can see that just as with Harpo, we've accepted Harpo. We've set cut-offs from Harpo, but we're not accepting this data, which I don't quite understand. It's illogical. And those women who are diagnosed with their GDM at 24 to 20 weeks, if you do scans beforehand, you can track this, but at 28 weeks, the relative risk for having an abdominal circumference above the 90th centile at 28 weeks is around 2. And those with an increased abdominal circumference at 28 weeks, they're fourfold more likely to have an LGA baby. Those babies, some of them for those who've had early GDM, they are already being affected, obviously. Does that map on to other complications? So it's Jinsi Emanuel, who was my postdoc, PhD student. And what you can see here, we looked at the different complications, done a meta-analysis, and you can see that there's a big impact on perinatal mortality if you've had early GDM diagnosed early. Neonatal hyperglycemia is up by about 60%, and of course they're going to be more likely to use insulin. Their glucose is higher, and their needs are greater. So this is from the DALI study, which was a randomized trial to prevent GDM across 9 European countries. And I excluded the women with early GDM from the trial. You can't prevent something that's already there, you just treat it. So we can divide those in the whole study, in the cohort, those with early GDM in red, those with later GDM in grey, and those with no GDM in black. And what we find is that those diagnosed early have a significantly higher HOMA, higher than those with late GDM, which is higher than those with normal glucose tolerance. But it is all part of that kind of bundle of metabolic syndrome and their response. They've got a higher first and second phase into response, but higher waist, blood pressure, triglycerides, and free fatty acids, all of which are going to potentially have an effect on that baby. We need to identify them and manage them. But the key question, of course, it's fine to say this is our theory. It's fine to say this is a correlation. It doesn't tell us whether treatment is of benefit and that we're not doing harm. So will treatment of early hyperglycemia improve outcomes? And you saw that meta-analysis, and I don't use and include those because the ECHO trial was really not a good trial in lots of ways. It's completely underpowered. But there was a large real-world cohort study from Hawaii and Northwest USA, and there what they did is they, across the population, they switched to screening for early GDM in the first trimester for those women with a BMI above 30. And then they compared the rates of complications before and after the switch. So 40,000 women, 9,000 with obesity. The GDM diagnosed was only 6.6%, they're using Carfilzomib, but across the population there was an 11% reduction in LGA. Across the obstetric population. And there was an 11% reduction in cesarean section. The women with GDM, and these are the ones that we're interested about in our management, the LGA was halved. The cesarean section rate was down by 22%, and as we expected, insulin treatment went up. So here's some real-world evidence about what happens when you switch to early treatment of that early GDM. But it's not a randomized trial. So randomized trial of toboggan, the New England Journal is happy with it. They're a bit naughty. They changed what we said the day before it came out. They made me put the word modest, which I now hear used around the world, that it's a modest impact. It was not a modest impact, it's a substantial impact if you have a look at the whole set of data. And the hypothesis was that treating early GDM, booking GDM, reduces the sequelae of maternal hyperglycemia and has no harms, was the second part. Multi-centre, 17 sites, Australia, Sweden, and Austria, and Chennai here in India. And it's women aged 18 years or more single-term pregnancy. But you could only get in if you had a risk factor for hyperglycemia. But ethnicity is one of the risk factors. So for any non-European ethnic group, all of them were invited in. So these are total population for non-European groups. GTT was between 4 and 19 per 6, but very few below 10 weeks, just the way things are. And we excluded women with pre-existing diabetes, no GDM. Those with a fasting glucose of 110, so this is that primordial cutoff. Chris Nolan for statin and no one with pregnancy. So we screened 43,000 women, and the GTTs were performed on 3,500 women before 20 weeks. We actually did not have many women not doing the GTT, and I actually think that there may be reasons for not doing the GTT for distance and a whole range of other things, but I think it depends on how you explain what this test is about, whether the women are going to do it or not. And we had 802 in the sample who actually had early GDM. It's multi-ethnic, so 23% of this sample is South Asian. So this applies to India as much as others. Mean BMI 31 to 32. H1C 5.2%. H1C to predict or detect GDM is hopeless. It's about a 3% sensitivity is what we found. It has some uses maybe, which I'll come to. And 23% were diagnosed before 14 weeks. So those were randomized to the early EM treatment, 406. They were just treated all the way through. They did not have a repeat GTT. They're being treated. Why would you do a repeat GTT? Those without treatment were randomized instead. You don't have to go to the clinic. We actually also had decoys. Those with the normal GTT, and we flagged them and we mixed them all up. You couldn't tell who had early GDM and who didn't. So this was blind, it was only masked. And then they would have a repeat GTT, and of course we managed to count both outcomes. So just a little bit about what we found in the baseline data. So if you look at the alteration of early GDM by ethnicity, then Mari and Pacifica, Polynesians, very big people, and from the Middle East, their odds ratio for early GDM was 1.4 versus the background of Europeans, but South Asians and Southeast Asians had over a twofold risk. So unfortunately, you are a very high risk, Indians are a very high risk group of early GDM. But what about late GDM? Because no one's really accepted this out. So in fact, for late GDM diagnosed at 24 to 28 weeks, unfortunately, South Asians are the highest there as well. So identifying the early GDM is important, but identifying the late GDM is as well. And just coming to some results, and when we repeated the GTT in those in the controls, and those were randomized to not having the early treatment, we found that there was regression in 33%. You know, glucose is a single measure, but actually it's in a part of a range. So you have to be very careful about that. And that's 22% in an upper band, which is those Canadian criteria, 95.162, but half in the lower band. And so we were worried, and we're saying, look, we're not going to be treating these women, and yet they have a high glucose early on. Does it matter? So we compared those women who were not being treated, who had regressed, with the normal women in the group, adjusting for BMI and so forth. And in fact, those women had no increased risk of adverse pregnancy outcomes. So those women, and this is for any GTT, any glucose test, the glucose challenge test as well. Glucose is a continuum, and we keep on trying to think it's one number. So we need another paradigm shift. It's not just about pathophysiology and the early diagnosis. We need a different model of care, which came up kind of as a comment before. We need a model of care that allows non-escalation, and we need a model of care that allows de-escalation. If a woman's doing well, but dark alone, what do we need to do? Do we really need to act on them the extent that we do currently in terms of attendance and monitoring? And these are the primary outcome: birth less than 37 weeks, birth weight 4.5 years or more, birth trauma, neonatal respiratory distress, not just respiratory distress syndrome, which is 2%, also any 4 hours or more of support. 80% of those turn up into the neonatal intensive care unit. So it's not just about the distress syndrome. Need for further therapy, stillbirth, neonatal death, child dystocia, like that. And 15. But if you look at those in the higher glycemic range, 7.8%. They usually say if the threshold is 8%, you should just introduce it. That's using those Canadian criteria. The WHO criteria, not much impact at all. 2.5 is the point estimate. But if we diagnose under 14 weeks, then the absolute difference is 8.9%. That's numbers needed to treat 11. So this is this is an important intervention, not modest at all. After 14 weeks, probably underpowered to show benefit, but it's still up to 5%. And mapping on to that respiratory distress and the other complications, we do an absolute reduction in the special care nursery, 0.88 days. So I think that's pretty major. And overall a 40% reduction. There was not much difference in the LGA rate because we were treating the GDM at 24 to 28 weeks, which is very effective for that. But we did have fat mass differences, and there was a reduction in third and fourth degree tears. Maybe that was by chance, but that's a 77% reduction, 3% absolute reduction. An improvement in quality of life, and this thing that kind of bubbled up on the SGA. And overall, a non-significant increase in SGA by early treatment. If you looked at those in that higher band, the Canadian criteria, then the odds ratio is only 1.1, so no impact in the higher band. But in that lower band, the odds ratio was 1.75. So treating early GDM using the WHO IDPSG criteria is a substantial increase in risk of small for gestational age babies. Think about that around the costs of this, and I think in India, my understanding, this is quite important because it's about who pays. So there's an increase in the glucose tolerance tests, increase in fingerprint testing, medications, and who you see, which I think is out of pocket for the women and the families. But the costs that are saved, non-significant delivery and special care nursery, I think those are paid by the public purse, aren't they? Is that right? So this is quite important for you to think through, because what we're doing is we're letting the women pay to save the taxpayer costs. And I don't know whether that is something you can do with. But if you have a look, overall, very much a dominant strategy, non-significant overall 1,300. But if you diagnose women under 14 weeks, in Australian dollars, in the Australian system, we save 5,500 Australian dollars per woman with a GDT. Some savings 14 to 19 weeks in the upper band, but in that lower band, it's more costly. Those smaller babies and all those other aspects mean it's not really useful using the WHO IDPSG criteria early on. And some people in the discussions, I don't know if you've heard any of this, say, look, that increase in costs was because of 1 or 2 or 3 or 4 very expensive NICU stays of, 100 days, which wasn't true, but anyway. But this is called a cost effectiveness plane, and you budget those who are in the intervention and treatment and control groups. And in fact, it was more effective. The early GDM treatment was more effective and less costly in 84% of the women. So really, I don't think that's really modest at all. I think that's really negative. What about if you delay? What's the degree of risk? So the composite outcome, which I mentioned, is 59% higher if they've had early GDM, early and late, and you treat them late. So if you treat late, you've still got that 59% increase in those adverse pregnancy outcomes. But with the late GDM, it's 19% non-significant, but I think it reflects we still need to treat that late GDM, and I'll show you some evidence on that. One of the things that was particularly unexpected was we looked at what was happening to breastfeeding initiation. As all of you will know, women with GDM, usually their breastfeeding is down by about a third. Whether that's because they've been to NICU or section or whatever it is, it's usually down by a third. And again, we found that treated as late GDM, it was down by a third. But the women treated early, they had no reduction in breastfeeding initiation. talk about how important these things are as part of a life course. Breastfeeding, I think, is pretty important for that offspring, probably the mother. So what are the implications for clinical practice? We would say your gold standard, I don't think it's a BMW standard, maybe that's the rickshaw standard, is 75 grams, 2 hour GDT. 10 to 14 weeks, only because we can only get down to 10 weeks in the trial. And if the women can tolerate a GDT below that, I think that's very reasonable. But risk factors, we say, that's all in the pretty clearly. But how do we implement it? Can we do one test at 18 weeks between the two? What will that do? And what should we do at 24 to 28 weeks if we do an early GDT? So any ways to streamline uptake? And I don't know how many of you are doing early screening for preeclampsia risk with SFLT1, and of course, as we've heard, also for TAP and the other tests for Downs or the other complications. So what we're starting to do is we're starting to bundle the GTT with all of the other baseline tests. Why wouldn't you? And then people say, look, diabetes is almost the same thing, we're trying to minimize the risk. Can we do one test at 18 to 20 weeks? And this paper is just out. The Tesco study, and what they did is they randomized women to 18 to 20 weeks versus 24 to 28 weeks screening. If they're 18 to 20, they did not repeat it at 24 to 28 weeks. So they did not treat that incident GDM. And they treated the early GDM too late. So they found there was no difference in the primary outcome, but the babies, neonatal adiposity 34.5%, 18 weeks, 7.7% for those who are 24 to 28 weeks. So we think that the interpretation of this is it's too late to benefit from early screening, and there's harm from not treating the late second trimester GDM. So what should we do at 24 to 28 weeks? Because we've got our WHO criteria, but we've now got the alteration of 2 that we want to use early in pregnancy, and we don't want to confuse people. And the point about that band, which was my question before on the GEMS study, is if you look at those women in that band between, in this instance in GEMS, 92 to 98 fasting, 1 hour above 180. Again, we're clinicians, we want to know what happens to the women in front of us. Or the 2 hours 153 to 161. What happens to those if we treat them at 24 to 28 weeks without any early screening? Actually, even though on the total population there is no significant difference in LGA rate, the obstetric population, for those individuals, there's a 2/3 reduction in LGA, there's an 87% reduction in stillbirth death and major complications. Near hypoglycemia is up because you're testing for it. Preeclampsia is down by 92%. So really the 24 to 28 weeks is important, but they did not do early testing. So what's the balance here? If you do the WHO at 24 to 20 weeks, some women will probably benefit. We think about a quarter. But there's more service demand without benefit, and there's probably a risk of SGA for most people. If you use the higher ones, if you're treating the most severe early, then actually that changes the odds ratio later on, and there's no risk. So in Australia, we've accepted that risk. But we have some studies and hopefully to start looking in this band of those who are no longer treated and looking at different models of care. So Belgium, as I mentioned, they're doing the alteration too early and the WHO later, and we're doing those together. So what options do we have to try to reduce the burden on the women and the services? So those with an H1C of 66.4%, when you look at them, they will have some early hypoglycemia. So it's worthwhile taking that, when you take it early in pregnancy, looking for type 2 diabetes undiagnosed, then that's actually quite useful. The second area is not that you're using it to detect hyperglycemia, but you're looking to exclude those who are not going to go on to hyperglycemia. So I don't know how many of you were involved in the STRIDE study? Were you involved? It was just a 10 hours or something. So the STRIDE study that many of you will have heard about, observational study, Kenya in the UK, and you can opt out if your H1C is down at the lower end. They used a 20% cutoff. I don't think any of us want to miss 20% of women with GDM, but a cutoff of 10% actually works quite well. But we're looking at those numbers and analysing them on the cohort. What about different approaches? What about if you're in that band, we do minimalist glucose monitoring over a short period. Give them one tube, see what happens. Those going up will go up. The 1 hour glucose in the women who develop GDM later on goes up by 2 millimoles per litre. That's 36 milligrams per deciliter. If they go on to GDM. So you can spot them if you've got them doing fingerprint testing, and it's one pot. So there are other ways of doing things. And as we've heard, biomarkers, engines, other ways of doing things. This is really the new front line. So just to summarise, lots and lots of benefits. 73% SGA means in the low glucose band, use 95, 191, 162. Early implementation, bundled with maybe upstream, ways to avoid escalation, implement de-escalation. These are new models of care which will reduce the cost of the women and the workload on themselves. Still need to do the 24 to 28 week GTT at the moment, but maybe there are opt-out strategies. And one last thing that I didn't touch on is about pre-analytical glucose loss. I don't know how many of you do your glucose is in the lab. How many do you do it in the lab or for screening yet? They go to the lab. They don't do meters or anything. So how long does it take for your sample to get to the lab? They're in the lab. How long does it take before they're analysed? 1 hour. So within 1 hour, you still get perhaps 0.1 or 0.2. Are they collected on ice? Ice slurry? So in Canberra, they changed from taking the blood in the lab to taking it in a collection area next to the lab, but then putting it into a vacuum tube and it goes straight to the lab and gets immediately analysed. And their GDM diagnostic rate went up from 11.6 to 20.6%. So think pre-analytical. Sorry? Yes. It's something to think about, really. But it's one of the reasons why a single glucose doesn't necessarily tell you what you want. You need to have more, but you can't do more. So you've got to think more about how we do things. And in Toboggan, we actually had a study in Sweden where we compared citrate, those collected in sodium fluoride. We did this spun within 30 minutes, putting them on an ice, serum and plasma. And we found that in sodium fluoride, serum and plasma, over just 30 minutes, the glucose had gone down by almost 0.1 millimoles per litre versus the citrate. So things to think about, but I know it's difficult logistically. Logistics always kind of business. So just to summarise, hopefully you agree with me. It's time to move from this, the old way from 1980 and before, to this, where we look for early GDM and we treat it, but we also identify late GDM and we treat that as well. We've got a whole series with someone from Chennai's group and also Yashmi Gupta, where they're from India. Just a little bit more about early GDM in the Answer series. I'd like to thank funders and the women and our research team